Hello everyone. Today we are going to record our first podcast on shoulder joint. We have Mrs. Kavitha Vishal with us. Let me start by introducing her. Currently, Kavitha ma'am is an assistant professor at MCHP Manipal, senior scale, and she is also pursuing her PhD in field of rotator cuff related shoulder pain. So first question I would like to ask ma'am would be, what made you pursue PhD in the field of shoulder?
Hi Adit, thank you for having me here. I'm not going to give you an answer saying shoulder was my passion initially or something like that, but my interest has always been in the treatment of upper extremity disorders, and I've always felt really good while treating patients with upper extremity issues. So I think over the period of time when I started seeing patients, and shoulder pain is something that we see commonly in clinics, and that's when I guess my interest developed, and that's what I'm doing right now.
So I remember this incident. My dad had shoulder pain, and that kind of started when I pushed him to be more active and start doing close kinematic chain exercises. He was like, no, I can't do push-ups. I used to do it earlier, but now I'm too old for that. And I kind of encouraged him. He started, and as he started progressing to ground level push-ups, that's when he started developing this pain in the shoulder, which was very looked like a pain which stemmed from rotator cuff. So then I started with some eccentrics and some first isometrics for external rotation, and eventually he got better with the pain. But first, before I intervened, he went to an ortho and they took an MRI and they said there was some impingement, and it didn't really help him. They gave him some medications and nothing really helped. And he used to have this pain while wiping the top surface of the car. That was the typical pain that he used to say. So that's when I was just wondering that when should a person actually take the pain seriously, and is it okay to kind of wait for the pain to subside, and can it be detrimental if you do it for a long amount of time? Can the tear, if there is a tear that we say, can it get worse, or is it good to show it first and go on with the rehab?
Okay, so as you mentioned, you can have both traumatic as well as non-traumatic causes of shoulder pain, and majority of the cases might be non-traumatic in nature. Okay, so in case if there is an acute episode, anyone can always try applying ice and giving it some relative rest. So when you say relative rest, it's not doing the provoking movement. Okay, but even after that, if you feel that your symptoms have not reduced, or if it is still persistent and if it is recurring, then you should probably seek medical help.
What can be the time period for this kind of pain? Like, how long should they wait it out?
Okay, the maximum for an acute injury to be subsiding might be over a week or something like that. You should definitely see reduction in symptoms, but sometimes you feel that it's it's getting aggravated with movements. It usually disturbs your sleep at night. So when those kind of functions are altered or are difficult to do, then probably you should seek medical help.
Okay.
And answering your other question with respect to would it be detrimental if you delay treatment? Yes, it would be detrimental, because usually we see that as the episode becomes chronic, then the issues become multifactorial, and then probably it's a little more challenge to treat such patients when compared to when the source of problem might be really simple.
Ma'am, could you just elaborate on the point multifactorial, because I kind of get it, but I would like to have a better explanation.
All right. Okay. When you talk about multifactorial problems, you can initially it might start with a local structure at the shoulder. Then you can get other tissues involved. And other factors, like usually we say that psychosocial factors also might influence chronicity. But obviously these factors are not much established in the Indian population. But obviously if you have a patient who is having symptoms in the dominant hand, if they have to do a lot of work at home, if they have caregiver roles and everything, it can seriously impact their day-to-day activities.
Okay, ma'am, would it also involve, like, when there is pain, it can change the firing pattern of the muscles in the scapular region? Would that also be a part of multifactorial, or that would be something else?
Yes, that can also happen, right? So you can have either strength or control issues of your glenohumeral or even your scapulothoracic muscles eventually as the patient moves into a chronic state.
Okay.
Yeah.
So, ma'am, as you mentioned this glenohumeral thing, it just reminded me of the whole idea of the glenohumeral space reducing and the impingement happening, the bone acromion kind of pressing over the tendon and creating the pathology. So I've been listening to other podcasts and like reading up, and it kind of seems to me that this kind of model is kind of going out and a new model is coming in. So would you like to talk about that?
Yeah, I guess, when you talk about specifically, since you mentioned impingement syndrome, primarily we believe that, it would be because of compression of the tendons, right? But right now we also know that it can be because of intrinsic degeneration of the tendons. So there can be one spectrum which is, extrinsic impingement, where you have compression of the tendons because of some issues in the subacromial space, or you might have an intrinsic variant where there is increased tensile loading because of occupation or because of age-related degeneration, and then gradually the rotator cuff, decreases in muscle performance. Okay, muscle performance of the rotator cuff might reduce. Now, mostly when clinical scenarios, I would say that you see a combination of both. You might see compression as well as degeneration, because usually these patients are over the age of 50 and they come with some problems like this. Okay, but I guess when you're talking about structural diagnosis, yes, I agree. I think we have moved away from that point of structural diagnosis. Now we have more of, for example, you have something called as shoulder symptom modification procedure. Okay, that's actually developed by Dr. Jeremy Lewis, where he talks about applying certain maneuvers, okay, and then see the influence of these maneuvers or procedures on the patient's symptoms. And whichever a clinical procedure reduces the patient's symptoms, that can be considered as treatment. Okay. Or you have something called as the star shoulder classification system, where you divide the shoulder based on shoulder problems based on a pathoanatomical model, where there are clear division into rotator cuff or AC joint dysfunction or shoulder instability. So you can go with any of these classification systems, and you also have certain mechanism based classification. For example, pure nociceptive pain, or people who have central sensitization. But I guess in clinical scenario, it's always better. As a physiotherapist, I would say that it's you can't really follow these classification systems, because even those tools that you use to classify these patients into these conditions are also not very good and definite. So as a physiotherapist, I would say that instead of depending on structural diagnosis, you should probably go into a detailed history, understand the patient's problems, find out what do they consider, what is their current knowledge of their condition, and what do they think are their the expectations and their perspective on their condition, and also anyway you are going to perform a thorough evaluation, and you will pick up impairments, right? You'll pick up impairments in the shoulder, you might pick up impairments proximal and distal, and then intervene on them. That would be much better instead of going in for a structural diagnosis.
So the first model that you mentioned, that is based on the symptom, you decide the treatment.
Yes.
That would be very similar to a McKenzie type of approach. Would you say that? Because like flexion based exercises and extension based exercises that we do for back.
Yes, probably, yeah. Something like, you perform a particular for example, if you notice that a person has an increased thoracic kyphosis, so you correct the thoracic kyphosis and see if that brings about a change on shoulder symptoms. Or let's say if a patient has a protracted scapula, so you correct the scapula and then see what is the impact on the patient's symptoms. So whichever maneuver reduces the patient's symptoms, that would probably be probably the way that you want to treat the patient further.
So ma'am, another question I had was, we know that the shoulder joint is compactly packed. There are so many structures in the very same spot, it's tightly packed. So there are so many structures around. And I would like to ask, what is your strategy to kind of distinguish between the structures that are there around the shoulder joint? And how do you go about it?
Okay. Right now, I think to distinguish structure, I guess that's why I said initially itself that structural diagnosis is something that I don't really look for, because right now usually when you say structural diagnosis, in clinical scenarios the only easy way to do it is by doing a special orthopedic test, and that is like everyone's favorite. Okay. Yeah. Everybody who sees a patient probably does that first before even talking to a patient. But I think heavy dependence on special orthopedic tests is not good, because definitely they have a lot of advantages. They are easy, they are readily available. You can just do it without any instrumentation. But the factor that you need to consider is that though they are developed based on an anatomical basis, saying that they are going to compress a particular structure or put a particular structure at stress, we need to know that, as you said initially, that it's a very compact area. So when you apply a special orthopedic test, definitely it's going to stress more than one structure.
Yeah.
So, and also you need to know that especially tests for the cuff are like the cuff itself is it merges with the capsule. Okay, it merges at one single tendon.
Yeah.
So when you stress, so if you just testing the subscapularis, you can't really say that you're checking only the subscapularis, because it is an entire structure by itself. So I guess dependence on special orthopedic tests is not good. As I mentioned, in my clinical practice, I generally go in for identifying the impairments, and also a lot of history taking, okay, identifying that it is a true shoulder problem, identifying the functional limitations. And then one thing that I always do is I try to align my assessment with respect to the chief complaint of the patient. So when you try and change that, that's when they see maximum benefit and they will come to you. So I guess that's what I do generally.
So ma'am, once you have come to a conclusion that okay, these are the functional impairment that the patient has come across.
Yes.
Say like if we had taken the example of my dad, he's wiping the car top and he gets pain in the shoulder. So then how would you go about it after this, like the assessment part?
Okay, the assessment part is to again find out primary impairments. For example, is there a mobility issue? Okay, whether there is a strength issue, whether there is control issue, and also identifying, probably for your dad, identifying, okay, this movement is probably producing symptoms, okay, why it is producing symptoms. And also when you try and assess, when you try and give him, if you have identified some strength or mobility issues, you address that, and then you reevaluate the same movement and see if that has brought about some change in his symptoms.
Okay. So will this treatment also be combined with patient education? How much of patient education do you actually use in your treatment, and what do you think, like how big of a role it plays, especially for Indian population? I'm curious to know about that, because the Indian population is very different than what we see around. So
in that I think I'll have to completely agree with you that Indian population is not someone who likes to talk about diseases. We don't talk much of diseases, even with family or with friends. We're not some people who like to speak more, and especially with respect to musculoskeletal disorders, never. You wouldn't see that amount of disability. I have not seen, probably I can't say it on a larger scale, but musculoskeletal disorders may not be of that much of a concern. But I still feel that patient education, definitely yes. And patient education is important to tell them, what are the things that they need to avoid, what are the things that are good for them, the importance of exercises, how exercises can be beneficial for them, what are the movements that we should probably not do, do's and don'ts. So I think education plays a really big part in the management of these disorders, and probably I would say that would be the first intervention that you should try before even intervening at a very tissue level.
Okay, meaning manually doing something, just giving them the whole background of
not concentrating only on passive treatments, okay, because even if you take shoulder disorders, a lot of evidence is there with respect to the use of exercises, okay. The same way self-management is also important. So it's important that the person is able to manage their symptoms on their own, okay, as well as listen or follow the instruction of a healthcare provider, and then take care of their shoulder.
Yeah. So ma'am, when it comes to like a rotator cuff related pain, the road for your recovery, it's not always a straight line, right? There are definitely ups and downs.
Yeah.
So do we also tell that to a patient, or will that take the confidence out of them? And what do you do normally?
Normally, yes, I think it's very important to tell them about realistic goals. There are a lot of other risk factors that might play a role in case of such patients. For example, age is a factor, so you don't know how much recovery can usually happen when you have a patient who has a rotator cuff problem beyond 65 years of age. And also, other factors like comorbidities, like diabetes, can complicate situations for you. So I guess it's to set realistic goals. It's to say that we'll work together, and we'll see how much of it we can improve. And then eventually we'll definitely find out when improvement happens, whether we're going in a straight line or whether we need to take varied paths.
Yeah. Okay, ma'am. So moving ahead to your area of specialization, that is the rotator cuff related shoulder pain. Would you like to just speak about it first?
Yeah, sure. So, rotator cuff pain is something that we see very routinely in clinical situations. I would say that majority of the shoulder pain conditions can be connected some way to the cuff in some way or the other. So let's say around 80% of your cases that you see, at least what we see in our clinical scenario, is mostly rotator cuff. All right, and the second category of patients are those patients primarily who complain of stiffness, what we call as adhesive capsulitis or frozen shoulder. So other than this category that you see, cuff problems are maximum, what we see routinely in clinics. And when it comes to cuff problems, usually we have a patient who is slightly over the age of 50, we see mostly males as well as females, and the dominant shoulder being affected. And classically, the patient would give you, a picture of pain with overhead activity, especially while taking the arm up as well as while coming down. They have lack of control. They'll also have a lot of issues with respect to getting a good sleep at night. Okay, so that sleep disturbances would be there. Most of these patients in the initial stages, we don't see much restriction in shoulder movements because the primary factor will be only pain with overhead activity, and especially when they have to do any activity beyond 90 degrees of shoulder elevation, whether it's flexion or abduction, that's when you see symptoms. But over a period of time, we do see these patients developing restrictions in specified directions, like for example, internal rotation deficit might be there, or things like that usually come, and then it takes a picture where you will have mobility issues, strength issues.
Okay.
So that's how it behaves.
So ma'am, we speak when it comes to rotator cuff, we always talk about the painful arc.
Yes.
So is the painful arc, the pain that we feel during the painful arc, is it because of the actual compression that is happening, or would you say it can be because of the movement that you are doing against the gravity, and in that range gravity is acting the most? What do you have to say about that?
When you say classical painful arc, you don't see that in majority of the patients. You may not see a classical painful arc, but you can say that it can be either because of actual compression, or when you have a weakness of the rotator cuff itself, it can cause superior translation of the humeral head and then cause a painful arc in a patient. So it's not just when you say compression, it's not just mechanical compression where you say only the shape of the acromion or a subacromial bursitis may cause a classical painful arc. It can even happen when you just have a decreased performance of the cuff, so the humeral head is not centered, and then it can migrate superiorly and then end up having compression as well.
Okay, yeah, that makes a lot of sense. And also, like the reduced strength, that apart from it stabilizing the humeral head, just the rotator cuff working in that range, would it be also one of the reasons? Just the because physiologically the cuff is damaged, so that working in that range?
The cuff is actually working through range, right?
Yeah.
So when you say shoulder elevation, it's not the activity of just the cuff. There are a lot of muscles that are working, but cuff is an important contributor to stability as well as mobility at the shoulder. So when the cuff is compromised, you have an altered pattern. There are some other muscles which are taking over the function. So definitely there is a change in pattern which might produce symptoms. Now again, when you say pain, you cannot say that it is coming only from that structure, because pain is subjective. There you can have an involvement of multiple factors. It could be how the patient perceives the pain, it could be with respect to other risk factors, it can be. That's why you have to explore the patient in totality and identify how they have responded to, if they have a history of shoulder pain, how's their experience been at that time, okay? What has been their experience with treatment of that shoulder pain. Those are also important factors in your pain perception, right? So you can't directly make a connection between pain and structure. A part of that pain is explained by the structural involvement, but there is another part which is determined by other factors as well.
So, ma'am, could you elaborate or give an example on how pain perception can affect the previous experience or something like that can affect the patient's pain perception and how it can be subjective?
All right. So it could be. So recently, I had a patient who had, who had to take care of her ailing mother. So naturally, she had a lot of work to do, and that itself was like that itself had a significant impact on her perception, because she was always worried, and she was kind of developed. She was also old. So the patient that I was treating was also 50 years old, and then she was taking care of her mother. So that's and she was alone. So, and also the fact that she was also developing symptoms on the other side. So that itself, kind of puts a lot of, it's a stress factor for a patient, right? So definitely, I think that's the perception. So she was worrying whether I'll have similar symptoms on this side. And also she had taken, a bout of physiotherapy before. And she was given some exercises, but she didn't really continue it, so she didn't benefit from it. So she thought that maybe, those were not physiotherapy might not be the solution for her. So I guess those things give you a lot of uncertainty for the patient, right? From a patient point of view, you need to understand that, okay, I have this pain, but I have taken treatment, but it hasn't subsided with that. So what's the future course? So they always have this uncertainty, and I guess during your examination, it's very important that you just don't, concentrate on just what you want to find at the shoulder, but rather than talk to your patient and identify these, thought processes as well, because you can incorporate that in your management.
Ma'am, how would you manage?
Yeah, answer your question.
Yes, ma'am. Yes, sure. How would you incorporate something like this in your treatment?
Yes, so that's where the role of patient education comes. So you and your patient sit together. You identify, what are the factors that they have at home, okay, and also what are the difficulties that they're having with respect to their upper extremity function, okay. So then you decide that you've also done your assessment regarding what needs to be evaluated. So based on that, when you target those impairments, and if you're moving in the right direction, if you can show some improvement to the patient, naturally, they gain confidence. So a lot of it also depends on how much confidence that the patient has on the therapist. And also, it's not nice for us to say that we can fix all your problems. Yeah. It's a combined decision making process. So I'm not, I cannot be God there and sitting there and saying I'm the therapist and I'm going to fix all your shoulder problems. It's something that we need to, sit with our patients. See, these are the things that I have, and these are my tools. This is how I can intervene. So let's see how it happens. So I keep those options open for patients and don't really try to, emphasize on saying that, okay, this physiotherapy is the solution. Yeah. I never do that.
So, ma'am, what would be your opinion on physiotherapy versus surgical intervention? What is the current evidence saying?
All right. So, with respect to emerging evidence, surgery as well as physiotherapy, most of the reviews say that they have equal benefit.
Okay.
All right. So, if the surgeon has made a structural diagnosis, and if we feel that structural diagnosis is a cause of the patient's impairments, then definitely surgery is a good option. But I would always suggest that a preliminary, session of conservative management is always good, at least for a period of few weeks, and then see if the symptoms are reducing. If the symptoms don't reduce, or if they're still persisting, and in case if they worsen, and even if your patients, I think the most important thing is patients with shoulder pain should know what are the available options of treatment. And they should be well aware that there is surgery, there is physiotherapy. So they are confident that, okay, if one doesn't work, I can always move on to the next, and that could be a solution. So they should be informed. And a well-informed patient will always make a decision regarding what would be the best management, because ultimately patient is the king. So it's very king or queen. So you have to decide based on that. And also, as I mentioned, a bout of conservative treatment, and if that doesn't work, then definitely a patient can be referred for surgical management.
Ma'am, what about the option of giving injection like steroid for the patient?
All right, steroids really don't have much evidence, but they definitely can, bring down symptoms. So there are evidences regarding combination of steroids and physiotherapy, and then they give sometimes beneficial effects. All right, so again, it all depends on whether the symptoms are acute. Probably they may have a role, but in chronic conditions, I don't think they have much use.
Okay. So coming to the treatment options that we were talking about, patients have. So it will obviously change according to the population, right? So if we compare the Indian population with the non-Indian population, let's say, so how will it differ, and what do you think is good for the Indian population? Like, what works according to your experience?
Okay, for the Indian population, you mean in terms of treatment?
Yes.
Yeah, so for the Indian population, I think the first important challenge that we face is to tell them that exercises are good, movement is good. So that's one challenge that we face, that most of the patients feel that they usually you see these problems with patients who have insidious onset of pain. They'll gradually restrict movements of the shoulder, and then they come back with major restriction in range of motion. So I think in the Indian population, the most important factor is to tell them that movement is good, okay, and exercises are beneficial. So if you have targeted that, and if you've changed that mindset, I think most of it comes under control.
Okay. Just a follow up to that. When you say Indian population, would it be all age group categories, or is it more of the elder population and younger is having a different mindset? Have you seen any pattern like that, or it's just the same?
No, yeah, definitely you see a mindset. I wouldn't, again, when I come here, I cannot say that, you cannot go with a stereotypical pattern that Indian population means they'll not do exercises. It's not like that as well, because things are changing. So you have a younger population which might do more. They do a lot
go
of
on YouTube and search.
So they do go on YouTube, they work out, they want to get back to workout. So anything that you say, they want to get back to workout, So that, yes, so both extremes are there. It all depends on how informed your patient is. So I will not say that Indian population is something that is a group of people who do not understand the importance of exercises. No, I think that's not my point. Okay, my point is we are not a population who sits across and talks about pain and solutions. How it happens in the Western. I'm imagining this probably that happens in the Western population, because we don't really know the scenario there, but we don't sit across and talk a lot about the condition. So I guess that needs to change.
Yeah, it's more of like the approach over here is like I go and they fix me.
Yeah, I go, I see the surgeon or the physiotherapist tells me the problem, and then this is my problem and I need to do this. So you will always have a patient telling you that this particular person told me this. Okay, fine, that's good. But, a dialogue, I think it should not be just one-way communication. I think a dialogue with the patient is much more important than just one-sided interview. I feel that will sort a lot of issues.
Okay, yeah, ma'am. You can continue with the.
So as I was mentioning that in patient education is important, especially in certain group of patients, and also you may either have a patient who doesn't do exercises or who does a lot of exercises. So those kind of things you need to take care of. Then mostly we see in the elder age group. So in the elder age group, we can't really see how the recovery will go. So as I said, it's not a straight line. We mentioned that before. So you will have to, try looking at the impairments. You need to address the impairments slowly, understand the pain intensity. The duration of symptoms also will make a role, because if the intensity is too high, then you cannot progress that fast. You have to take care of that. Then you also have to take care of the duration, because chronicity, it will take longer for you to get things back to normal. So those are the factors, I guess. I guess it doesn't vary much with respect to any population as a whole, but certain things that you need to tailor make to our population is important. Yeah.
So when do you actually decide, okay, this patient needs a more of a passive approach than compared to a more of an active approach when it comes to treatment?
Okay, I don't think there is any approach where you can fix a patient's problem only with one. Okay, it's a dominance of active or passive, but always your aim is to move towards active.
Yeah.
So you cannot definitely use a unimodal form of treatment. You have to use a multimodal form of treatment. So there should be a combination of passive as well as active. That's what I would say.
So we'll come to the end of the podcast. One thing what you would like to send a message across to people who are watching, the population would be kind of students who are looking forward to expand their knowledge in field of shoulder / some people who have come with their shoulder pain and trying to find a fix or trying to look out for options that they have. So what would you like to tell them?
So for people who are physios, I will just tell them that shoulder pain is something that you might encounter routinely in your practice. Sit with your patients, talk to your patients. That's most important. And then identify their impairments. Don't really bother about what structure and where it's getting compressed, where it's getting weak. Identify the impairments, look at the functional limitations, behave like a physio, and then probably that is the most important thing. Don't feel that you can fix all of patients' problem, have that a little bit of uncertainty. I feel is always good. That will give you a lot of things to.
Yeah, that's something like uncertainty is something we always run away from, even in our lives.
Yeah. So you don't have to be perfect everywhere. It's okay if you don't know much about the condition as well, but never do any harm. So that's the most important thing. With respect to patients who have shoulder pain, we are there as physios here, so you can always come over and consult us. That's all. Thank you, Adit.
Thank you so much, man.